Hi, everyone. Mike Englehart, Benefit CFO here for another session of GameChangers. And with me today is Professor Thomas Campanella. He's the Dean of Healthcare Economics at Baldwin-Wallace University. And I am especially excited to have him here today. How are you?
Michael, I'm doing terrific, and I'm excited to be part of the program.
Awesome. No, I have to say I follow your podcast, and it's really your take on healthcare that is really interesting to me, and I think we agree on a lot of your different views. But the thing that is really striking is, in light of everything going on with COVID-19, how do you think that's changing things in terms of healthcare?
Well, actually, the way I look at it is you have sort of life during COVID, which is a very unique situation, as you would expect, both for us personally, but also for players in the healthcare sector. No matter what part you're in, the hospital side, physician, or any of the other areas. And then there's life after COVID. And I think we'll be talking a little bit further, but as we're going through this, all the key stakeholders, including us, obviously, personally, it is very, very challenging. And when you think about healthcare and who finances healthcare, you're talking about the government, which is Medicare and Medicaid. You're talking about employers, and then you're also talking about consumers. And then when you think about the challenges all of those are facing, you know that as we go through this, both as we're going through it now, but even life after COVID is going to be challenging for the stakeholders.
Absolutely. So when you really break down, the supply chain and you think of the different components of healthcare, which parts of healthcare or which players within that supply chain would you say are the most affected?
Pardon me, I apologize. I would put it, from a healthcare standpoint, and I think most people would come to the same conclusion. It's hospitals and physicians. And when you're thinking about the hospital side, it's really those hospitals, for an example, rural hospitals who are already having challenges prior to COVID are definitely, because of what's happening, are in a much more challenging position because they were struggling for survival before this, and their margins were very, very thin. And then you have something like this happens that impacts them from a number of different ways, including obviously their ability to be able to do elective procedures and those types of things. And then as you talk about hospitals in general, you really got to focus on especially those hospitals in the hotspots. So the one that I think we're all very much aware of from a hotspot standpoint is New York City. So those hospitals are especially challenged financially, all types of hospitals. And it's a major, major impact. Now, hospitals in other areas of the country that came into the COVID with some pretty strong balance sheets and real strong financial positions, and they're not really a hot spot today. While this has been impacting them, it's nearly not even close to the degree as happening to those that are like in the New York City area. The other group that's impacted, and in some ways even more impacted, Michael, are independent physician groups because they don't have those reserves. And then when you think about physician groups especially, their source of revenue, the reimbursement that's used, is basically a fee that they get for either seeing patients or doing procedures. And as everybody knows, during this time, that's not happening. So it's drastically impacting their cash flow, and especially primary care practices, which have real small margins of profitability, are definitely hurt. And I'm really concerned about many of them from a viability standpoint.
Absolutely. And, I think you hit it right on the head. And one of the things that people are starting to get used to are things that actually they weren't used to before, like telemedicine. And now that's really the only way you're interacting with a primary care physician. And so I think we're kind of on the brink of change. At least that's my personal opinion. And that's kind of brings me to my next question. Um, do you think once we get beyond this COVID-19 and the pandemic and the quarantine, do you think we're going to get back from a healthcare standpoint to the norms that we're used to, or do you think there's going to be any changes once we get past this?
As I mentioned at the beginning of this, it really can't be business as usual because, and again, you don't need to be a healthcare expert to come to conclusion. When you think about Medicare, Medicaid, employers and consumers are the ones that finance healthcare. And when you think, for an example, at the federal government level, especially as it relates to even Medicare, which is obviously the major entitlement program along with Medicaid. The federal government was already at historic highs in the deficit. And then we're all aware of the financial packages that are out there to be able to sort of keep the economy running and also to address all the needs, from an income standpoint for those millions and millions of unemployed. So there is going to be less resources available from the government. Employers, most employers are dramatically hit by this. And then obviously the consumers, and so many of them have been challenged, from this, and many of them even lost their health insurance. So the bottom line, it can't be business as usual because the resources aren't there. So what's going to have to happen, which I sincerely believe in the long run will be the best for healthcare, is that whole model, that change that we've been talking about for decades that we need to have in healthcare. In many ways, are going to be forced upon us as a result of what's happening with COVID.
Interesting. So, so when you think about that new model, I mean, clearly, yeah, from a payment reimbursement standpoint, I totally agree that has to change. But that really makes me think about primary care and what their role is today, and maybe what it should be. Because in my mind, I think of primary care, or my primary care physician, is kind of my liaison to the entire industry, the doorstep to the industry. What do you think about that?
Well, when you think about it, and that's where I think the real opportunity lies, Michael, is primary care is in effect that first stop, or in reality should be the first stop for individuals in regards to the whole healthcare paradigm. And in their importance, and in fact, not too long ago, I wrote a blog, and in effect was titled, and this was before COVID, that primary care needs to move to the center stage. And when you think about what's needed to evolve our healthcare system from what I call, and a lot of people call, a sick care system, we take care of people once they're sick, to a real health system, keeping people healthy. And then when you think about it, what better way to find a use of our societal resources than to have healthy people? Because healthy people are a lot less expensive, and it's a classic win-win for everybody. Well, when you think of primary care, you think of, okay, what are the components of health? And what are the components of making sure, both from a population standpoint, but individually? And you say to yourself, okay, well, one of the components is adherence by the patient, where they really understand whatever health issue they have, maybe it's diabetes and that, what they need to do, say working on nutrition, exercise and that. Doctor tells them, but they need to obviously comply. What else? It's education, it's understanding. So it's one thing to sort of say, okay, you need to comply with what happening. You really clearly have to embrace it. And for patients, who are all of us, and I think we can appreciate that, to really sort of go that next step of adhering, you really got to understand what's happening. So that understanding, that educational part, is a real major component. Then when you think about it too, most of us, including me, because I'm not a clinician, is in a position where we really need to have a trusted relationship. And you say to yourself, okay, trusted relationship, you really need an advocate that really understands you in total, and to both have that trusted relationship to sort of confirm and help in that education and that adherence, but also be an advocate for you in regards to you traveling through that health system. Because you're going to, nobody stops. At a certain point, you may have to go to that specialist. At a certain point, you have questions about procedures. At a certain point, you may need to make decisions in regards to a surgery or no surgery. And yes, you can go to various specialists and get perspective, but you want to have somebody that really knows you, that trusted relationship. And what I'm basically saying is, you see, it's like a building block. All of those flow back to that primary care physician. And then when you take a look at the primary care doc, and when we're talking about the challenges that we're going to have, and we already have, in regards to the resources available for healthcare, you want to have that advocate that allows you to optimize whatever resources or services that you need. So you want somebody to actually, as your advocate, if referrals are needed, ideally refer you to the specialists that really make sense for you, that really, both from a cost and value standpoint maybe, but also from a quality and outcome standpoint. You need to have that physician that potentially can also be there with you in regards to determining maybe if it's a hospital setting or that, or a clinical setting, where some of those value propositions are. And then finally, which is sadly one of the big challenges we have, we've been talking about the electronic healthcare record linking all of us in for decades. And in other countries, including even with the VA, this is commonplace. But so many times when you go to your primary care doc and you've been to a specialist and you say, well, you do have my specialist information, they'll say, well, no, I was never given that, or I don't have access to that. And so one of the things societally that hopefully comes out of this is a recognition that we have to have, and really with teeth in it, a clearinghouse that really makes sure that your primary care doc, who understands you holistically, has all that information out there from all, not only clinical sources, but even in areas like social determinants. So that primary care doctor is the most valuable thing that can occur, both from a personal basis, but also from a societal standpoint.
Absolutely, and we could not agree more about the need for the right type of primary care relationship with a patient. But it really makes me wonder about how we're going to get there, because it really seems like one of the challenges is how to compensate a primary care physician, because you're talking about value, you're talking about things that have great value to a patient, but they're not necessarily charges that they can bill, if you know what I mean. How do you propose that we address some of those challenges?
Well, I think there's been pilots, tests, done in different ways. You have Medicare with their Medicare home concept, with their certain reimbursement methodologies there that they're, trying to do with primary care. You have different commercial carriers coming up with maybe creative ways to be able to do it. And then there's a lot of other entities that are looking at it. Ultimately, I think in the ideal way is the more, certain groups of people, if payers or others, or even employers, are in a position where they have that primary care doc, and ultimately being in a position where there's responsible for X number of patients. And it could be in a capitated model where, and they do this a lot with like Medicare Advantage plans, where you might have a contract with a primary care doc practice, and you put them at risk. It could be potentially even with employers having some type of relationship with primary care practices where there is some type of reimbursement model that incents them to not look at things on a fee or procedural base, but really, in effect, paid for almost like per person per month, whatever that happens to be. So if you have X number of employees, you take care of a certain site of population. There's, organizations too that do on-site from an employer standpoint or near-site models. There's a little bit of everything. I think hopefully what this is going to do is we do have lots of pilots, but that we start adopting best practices out there. Ultimately, you're right. Given what they need to do, it can't be procedurally based as it relates to primary care. It has to be more holistic and individually based. So it has to be more packaged that way. But there's definitely different ways that can be done. There's no one size fits all.
Absolutely. I'm seeing more of the some of those pilots you're talking about, and I'm seeing more and more being utilized by employers. I'm also seeing some of that direct contracting being done on the surgical side as well. It's really interesting. But I wonder, in your opinion, where does transparency fit into all this?
Well, see, that's where, when you talk about some of the challenges that we've had historically, and you say to yourself, okay, why do we have such high healthcare costs out there? Really what it comes down to, it's a number of different things. And one of them is what we've been talking about, is we have a payment system, a fee for service, in effect, both at the hospital and physician level, and that's pretty much tied into the more you do, the more you make. And it really sort of feeds into healthcare escalation. The other big challenge that we have, you couldn't model a worse system. Not only do we have a payment system that incents overutilization, but then you have a system where there's no transparency, where the people that are making decisions, like consumers or even employers as they're involved in the process, have blinders on and they're not aware of the costs. And so, I mean, you say to yourself, well, duh, it says it's you could, nobody, I mean, you could be, right out of high school or whatever, and you put those two together and come to the conclusion 20 years ago and say, you know what, you're going to have rampant healthcare costs. And guess what? You don't need a PhD to come to that conclusion. So sadly, when you think about it, you say to yourself, well, why? Well, then, if that is such common sense, and it's something that we have known for years, that we had a payment system that incents overutilization, and we don't have transparency, why are we talking about it today? And why didn't we do something about that 20, 30 years ago? Sadly, we spend a lot on healthcare. And guess what? Somebody's making that money. And so the players, bluntly, it's my slice of the pie. It's that they're in a position, the incumbents, whoever they happen to be, their piece of the pie, that benefit from such a system. In effect, they want to see change, but everywhere but their piece of the pie. And so they're in a position where, when we are looking for things like transparency, they're actually lobbying in Washington and other places to try to prevent it. When we're looking about changing to real risk/value-based type reimbursement, you get a lot of lip service, but when you cut through it all, we're really not even close to where we should be. So this is why we're in sort of a very unique time. And I know, it's something like COVID is really bad, COVID-19. But through great disruption, there's opportunities for great innovation and change. And I think that's what we're entering into now. So we have a very unique opportunity, and we can't let it get away, to sort of reinvent our healthcare system and make that system truly a health system.
Absolutely. Could not agree more. But I guess thinking about all those stakeholders that all, want their piece of the pie. Where do you see employers fitting into all this?
Well, that's the other part that gets me so frustrated. And actually, these are some of the reasons why I started doing blogs and podcasts, because I said, I can't, I have to vent somewhere. And my wife is telling me, hey, I don't want to hear this stuff anymore. So I said, well, I better find an outlet one way or another. So that's what I'm doing. But bluntly, I'm very frustrated from an employer standpoint. And in some ways, I don't understand. In some ways, I do. And where I'm coming from is when you think about employers, they're one of them and the government are the big financiers of healthcare. And you say to yourself, because of that, and if they're looking at their costs in their particular entity, that organization that has a major impact on their overall profitability, healthcare is like right there. I mean, there's not, you can talk about, like even Lee Iacocca back in the 80s was talking about, I spend more on healthcare than steel for the cars. So, I mean, it's a big thing. So you would have thought employers would have been really, really proactive to do something about it. And the two things they haven't done is, one, it's almost like they have a victim mentality. They think there's some by as it relates to healthcare and some of the issues. Yes, it can be complicated, but it's down to a lot of the basics. And in the bottom line, they have the power to really have that impact and do a change. And then the other part is that was really frustrating for me on an employer standpoint is being in a position where the relationships they've had with third parties historically, but historically over the last 20, 30, 40 years, they had relationships with third parties that, quote, help them manage their healthcare benefits. And basically, I hate to put it bluntly, and this is not obviously universal, but the fact is many of them were really, ultimately, those relationships benefited the third party more than it actually benefited the employer. And then sadly too, and this is hopefully changing, but a lot of decisions were made by human people in the human resources area, and they weren't interested in disrupting and changing things. And now two things are occurring. CFOs are playing a bigger role in this, as well as people in the HR area are recognizing that they need to have that disruption. And disruption isn't necessarily bad. All they need to tie that into is education and that related to their employees. So I'm starting to see changes, and the more they demand, they're still going to need these collaborations with third parties, but they got to make sure they got the right partners with them.
Absolutely. I couldn't agree more. And it reminds me of even some of my peers. The story I always tell is, I think it was back in the late 90s. One of the big insurance carriers lost a lawsuit, and it was over the fact that they had written a plan document on behalf of an employer, and it didn't have all the proper information in it. But at the end of the day, the insurance company lost. So what did they do? They stopped writing summary plan descriptions for their clients, for their employers. And in that same newsletter, I was reading that insurance brokers that were within that same lawsuit, the insurance broker was also found to be guilty because their commissions or their fees were coming from the insurance company, not their client, their supposed client, the employer. So it really made me think about my relationship with my clients. And from that point on, that's really the only relationship well, it's the type of relationship that I don't want to have, and I think more of my peers should be thinking about that. And just in terms of who's their end client, who are they working with, and frankly, who's paying them. But
Right.
as I think about the future, and you were talking about employers, what do you think I mean, what do you think they should be doing as employers to best position themselves for the future?
Well, I guess one of the things that they, again, one, they got to recognize that they do have the power, that they, both on an individual basis and employers collectively. So they, in effect, finance healthcare. There are ways to be able to shape the healthcare that your employees are receiving. I don't care if you're talking locally, regionally, nationally, as you would expect in any sector, in any industry. There's a whole gamut of providers from a pure value standpoint, in regards to how much value they really provide, how much quality, the cost of it, depending on what it is. And the more you can find creative ways, including benefit designs and other ways, to be able to try to direct care or incent care with employees to go to value-based care, you're in effect, even with that approach, you're reshaping healthcare as it relates to your employees. You're sort of redesigning it yourself. And then, depending on how many employers in a particular region have that same type of mindset, you can really, in fact, really change the whole healthcare paradigm in a community. Because then all of a sudden, when you think about it, because everybody's looking to survive, all the stakeholders, hospitals, everybody, physicians, and all different types of groups, is that the more the customer is demanding value, then ultimately, if that demand is out there and that is done through an employer in different ways, including that search for value, it's going to force the supply side to be able to be successful. They have to provide that value. So you're in effect doing not just good for you individually as an organization, but the more employers have that mindset, especially in a particular community or different areas, and especially the bigger they happen to be, the more you're potentially benefiting the entire community in regards to better quality care. So a lot of it starts with that mindset that we are not victims. This is our money and we can do something about it. And then the other point is we just talked about, Michael, at the beginning, the value of primary care and how they're the key player. So you say to yourself, okay, in some ways, when you think about employers and primary care physicians and practices and other types of linkages there, the more that employers can have a win-win relationship with primary care as well as their employees, and the more they utilize the right type of primary care for the right reasons, as we talked about earlier, it ultimately is going to be better for quality. It's going to have ripple effects on things even like workers' compensation, allow their people to be more efficient, just help your costs, allow you to have more profitability. And so all those reasons we talked about earlier, the importance of primary care, guess what? Again, the win-win is obviously primary care to be successful. They need to have those successful relationships, and employers are a key player that needs those successful. So in many ways, it's like a marriage made in heaven. So I think both the understanding and the collaboration is critical. And then finally, there's a recognition, different size employers may have in-house expertise, but there's going to be times where, as we talked about earlier, collaborations outside of the particular employer may be needed to accomplish that goal. And then that's where they got to make sure they're dancing with the right partners and that have the same vision as them and that are definitely in a trusted relationship.
As I hear you talk, and I can't thank you enough for all the time you spent with me. It's just, point after point, we're just in lockstep, and I totally agree with everything you're saying. And for anyone who's watching that would like to follow you more, you've mentioned a blog. How would someone find that?
Well, the best way is through LinkedIn initially. And so I'm on LinkedIn and it's Thomas Campanella. So Campanella. And then, and actually they can even reach out to me and, It's real simple. I'm a professor and director of healthcare business programs at Baldwin-Wallace University. And they can reach out to me even by email, which is tcamp, T-C-A-M as in Mary, P as in Paul, at BW for baldwinwallace.edu. And I would, definitely put them on my list. I actually do a monthly recap. And again, it's a combination of blogs, podcasts, webinars, and it.
Awesome. Well, Professor, it's really been an honor to have you here. Someone who's dedicated their life to healthcare. It was great hearing your thoughts in regards to what's going on and hopefully what's to come.
Thank you, Michael, and I really appreciate it. And just like you, I just love the synergy that we're seeing here today between you and I. And the more, in different ways that people, and I know this is part of your mission, getting like minds to come together, a lot of good things can come out of it. So keep up the good work.
All right. Thanks a lot. Take care.
Okay, you too.